Okay, looks like those of us who are joining, it slowed a bit, so I'll just keep admitting those who keep joining. So good afternoon, everyone, and thanks for joining us for our second pre-training webinar. I'm Ashley Sutphin, the project coordinator at CityMatch, if you weren't able to see me and meet me last week virtually. Today's webinar will provide you with a statistical and epidemiological framework for public health analysis, brought to you by Dr. Mike Smith. And a few housekeeping items before I hand it off to Mike. Access to our Microsoft team has been granted for each of you. That invitation should have been sent to your work email that you're receiving all training course communication to. Some trainees have shared with me if their organization already has a team account, that joining our training course team is accessible and more easily accessible through the web browser version, not the installed application on your computer. So if you already have a team, that may be the best route to go for accessing our team through that invitation link. So a helpful tip for those who are still working on accessing it. Once there, you can drop a note on the roll call in the general forum just to help me know if you've gained access or not. Second, I did share the needs assessment homework with you all yesterday, which is a prioritizing exercise, and those documents are available in the team platform as well. Please do try to submit your answers by Sunday, July 11th, so we can integrate those responses into Dr. Bill Sappenfield's training session this coming Friday. And evaluations, thank you to those who completed our first training webinar's evaluation. If you have yet to do so, please take the time to complete that evaluation alongside today's webinar evaluation, which will be sent with our recording from today. And just to again share with you that we are looking forward to getting to know each of you more and more with each session. Beginning with a fun icebreaker we have planned on Monday. We're looking forward to it. Bring your competitiveness. We're hoping this will be fun for you all. So we get to know you all a little bit more professionally and personally. The faculty are also working on scheduling office hours to meet with anyone individually if you have questions or want to discuss current projects, analyses, career development, or any questions. We are also working on scheduling a couple roundtable discussions. So those will be small group with the faculty, a couple of the faculty and your peers over the next 3 weeks. So stay tuned for details on those pieces. And with that, I would like to introduce Dr. Mike Smith, who is our lead faculty for the training course and an incredible member of the team who helps pull this training course together each year. So the floor is yours, Dr. Mike Smith.
All right. Can everybody hear me okay? Okay, good.
Sound good.
All right. I'm going to share my screen and try to set up my screen a little bit so that I'm not too distracted. Okay. Hey, everybody. I'm excited to be here. I'm really excited to have you here. As Ashley mentioned, we've been working on this course and trying to get it put together for quite a while now. And it's really exciting to get it kicked off a little bit last week, to continue it a little bit this week, and then really get into it next week. I'm really, really excited about the training course this year. I'm really excited about all of you, the cohort that we have, because you are all incredibly talented and you have great experience, and I look forward to all of us learning from each other. What I'm going to be talking about this afternoon, well, here it's this afternoon, at least. I'm going to be talking about statistical and epidemiologic frameworks for public health analysis. And this is stuff that I think is really fun and interesting, but most audiences that I talk to would probably roll their eyes and log off when they saw this title. So I expect and I hope that this audience is a little bit different, right? That maybe you think this kind of stuff is fun to talk about too. I think and hope that most of this stuff will be review of stuff that you've seen before, stuff that you're familiar with. That's my intent, is that this is just a quick review to make sure that we're all, have these things at the front of our minds. Some of these things you might not have seen or thought about much since grad school, for example. So just to rehash and to make sure that we're kind of all in the same place. So again, that's my intention. I'll go through this kind of fast for that reason. And also that I like this stuff, and sometimes I just get rolling. And sometimes I start talking really loudly. So if I start getting very loud, put something in the comments, or better yet, I might not even see the comments. So speak up and say, hey, tone it down. All right. So again, I'm Mike Smith. I want to give some acknowledgments to Dr. Deb Rosenberg and Dr. Kristen Rankin, both at the UIC School of Public Health in Chicago. They have worked on this course before. Deb Rosenberg was the first faculty coordinator for the MCH Epi training course. She was followed by Kristen Rankin as the faculty coordinator, and I took over this role from Kristen. So Deb and Kristen did such incredible work just setting this course up and making it just great. You may have seen in my intro video, if you've gotten into the teams and watched it yet, that I was a participant in this course in 2012 when Kristen was the faculty coordinator. She's just an incredible person. So is Deb. So I'm so, so happy and so gracious to be involved in this role. All right. So what I want to talk about today is really three big things. First is what do MCH EPIs do and where do we fit in public health? Then I'm going to talk about some tools that MCH EPIs draw from. The first set of tools I'm going to talk about are the statistical framework, which sometimes I'll call the sampling framework, because that's kind of the subset within statistics that we use most often is this sampling framework. And then I'll talk about the epidemiologic framework, and then big finish with a few closing thoughts. All right, so kind of contextualizing MCH EPI within public health. This should look pretty familiar to you. The core functions and essential services of public health, the core functions of assessment, assurance, and policy development. These essential functions, they were redeveloped last year in 2020. So if you haven't checked in on these in a while, this is a good time to kind of reassess what the essential services of public health are. Within the EPI world, sometimes we get boxed into this assessment wedge, where we're really looking at assessing and monitoring population health, investigating, diagnosing, and addressing hazards and root causes. But epidemiology is really so much more than that, right? Epidemiology is certainly involved in communicating effectively to educate, strengthening, supporting, and mobilizing communities and partnerships, definitely involved in improve and innovate through evaluation, research, and quality improvement, right? Epidemiology really is a big component of every section of the core functions and many of the essential services in public health. Really, epidemiology is very broad, as you know, because you work in epidemiology and you know what your day-to-day is like, right? So this is kind of one framing tool for thinking about where we are within broader public health. Another framing tool is this public health planning cycle, right? Where we do assessment, and then and through that assessment, we evaluate our capacity and we develop strategies for what we want to implement, and then we develop a plan, and then we start doing stuff, right? We implement the program or policy or whatever we want to implement. We monitor it in an ongoing way, right? Sometimes that's quality improvement. Sometimes those are performance measures, different ways of monitoring, and then we do evaluation. We make improvements, and then we're back at this assessment place, right? So this public health planning cycle, we can think about it in terms of an epidemiologist and an MCH epidemiologist role in each of these components of the planning cycle, which, you know, some great folks, including Deb Rosenberg at UIC, spent a lot of time doing, and they came up with this MCH epidemiology effort, which is based on that planning cycle. So it's things like on the planning side, produce descriptive statistics on a wide array of indicators, right? That's one thing that we do a lot of. Contribute to setting the MCH agenda, support prioritization processes, develop analytic plans, select indicators, set targets, and then when programs and interventions and things are in motion, we collect new data when it's appropriate. We monitor the progress on priorities and selected indicators. We conduct in-depth analysis of a few targeted health issues. We evaluate programs to document processes through process evaluation to capture impact through outcome and impact evaluation, and then kind of spanning the planning and the doing, right? Things that we're always kind of doing all the time at all these different places are disseminating and translating data, right? Interpreting, presenting findings, and promoting data systems, developing data systems, linking data systems, expanding data access, right? Developing new data systems, sharing with other jurisdictions to try to get better data, right? So I hope that you see some of the stuff that you do in this MCH epidemiology effort. It's certainly not all the things you do, and I've been an applied MCH epi for 15 years or so now, and you know, I have some idea of what some of the responsibilities are, and some of what I know, and again, I hope that you see some of your responsibilities in your day-to-day work listed here, but it's probably not all of them. But some of the stuff that we do includes data collection, descriptive analyses, analytic inferential analyses, results interpretation, data translation, literature review and summary, evaluating programs, managing programs. Sometimes they're related to data, and sometimes they're not even related to data. Supervising staff, sometimes they're data staff, sometimes they're not. Advising or liaising or assisting program staff, collaborating with researchers, writing grant applications, designing studies, informing program development, implementing program or policy programs or policies, monitoring trends and key outcomes, conducting needs assessment, presenting results to wide audiences, knowing all research and analysis techniques from memory, not having to Google anything, knowing the details of all the programs that you're working with, being proficient at least or expert in SAS, Data R, and SPSS sometimes, and other duties as assigned, right? So I guess what I'm trying to say is that MCH epi is a pretty easy job where you get to kick back a lot of the time and wait for the waves of money to come rolling in, right? Is this consistent with your experience? Yeah, okay. Good. Let me get back here.
In the chat.
So we do a lot of stuff, right? And a lot of variety of stuff, but we have kind of a core toolbox that we come back to for a lot of the things we do, certainly not all the things we do, right? In practice, MCH epi involves, a lot of HR stuff sometimes. It involves a lot of program management. It involves a bunch of stuff that is not always taught in epidemiology programs. But kind of grounding in some of the stuff that we learn in epidemiology programs, right? There's statistics and epidemiology, right? They're tools that we have for describing, explaining, and or predicting the experience of a population. Oh, before I go on, as a quick aside, I'm going to do something that I don't like to do and that I don't recommend doing. And in a couple of weeks, when we talk about data communication, I'm going to recommend not doing but I'm going to do it today. And that's have really wordy slides, right? I generally don't like to do that, but I'm absolutely doing that today. And I have a reason for that. The reason is that I want these slides to be a resource that you can look back at. So I'm trying to put like everything that I want to say on the slides, which again is a bad thing to do for communication, especially data communication. But I think that it's useful in this instance because this is kind of refresher stuff, hopefully, mostly, and I want it to be reference material. Okay, so these are going to be really wordy slides. I'm sorry, but there is a reason for it. Okay, so statistics and epidemiology, right? They're linked. They're not the same. So we're going to talk about them separately, but we're also going to talk about how they are all part of the tools that we use for describing, explaining, and or predicting the experience of the population. So the statistical methods provide the mathematical rules for estimating averages, population averages, and formally testing hypotheses about those averages. And then epidemiology is a set of tools that focuses on occurrences and patterns of disease, well-being, or other factors in human populations. So in thinking first about these statistical tools, what I want to talk about is the sampling framework, right? So we're estimating population characteristics, right, by taking a sample from that population. Okay, so we want to estimate these population characteristics and estimate the relationships between two or more population characteristics, and then test hypotheses about those population characteristics and the relationship between them. And on the epidemiology side, we have descriptive epidemiology, where we're really summarizing the distribution of outcomes, risk factors, risk markers in a community without trying to test hypotheses explicitly or causally explain things. Right? We're just trying to describe the situation. We're trying to get a good understanding of what's going on, and we're trying to, in many cases, communicate effectively about what's going on. Right? So descriptive epidemiology, and then analytic epidemiology, where we are testing hypotheses about risk factors and their relationships to health outcome. We often use analytic epidemiology to test hypotheses about health services, health policies, and social determinants of health, which we're going to talk about a lot over the course of the next few weeks. So these the sampling framework and the EPI framework work together. We have to synthesize these epidemiologic and statistical principles for almost every aspect of public health, right? From surveillance and monitoring to needs assessment to program development, program evaluation, policy development, advocacy, EPI research, and health services research, right? We're kind of using statistical stuff and epidemiologic stuff in all of these areas. And this is in contrast to clinical medicine, right, which focuses on individuals, right? Interventions and strategies for one individual at a time, right? Whereas public health focuses on the population level, right? Populations of individuals, or focusing on communities, right? So we're not, analyzing patterns of health and disease in a single individual. We're doing it for a population. We are applying programs at the population level, not the individual level, and customizing policy at the population level. And I think over the past year and a half plus, we've seen the tension between the individual level and the population level, play out as it relates to understanding COVID and COVID response, right? Whether or not recommendations are made geared towards individual risk or population risk, right? And there's a real tension there that many people don't understand, but we work on the public health side and on the population side, and that's usually the less well-known and harder to think about side, right? So it's an important distinction. Describing and analyzing the health at the population level means that we have to summarize data, right? We're working with a lot of data about a lot of units of observation. So we have to summarize it. We organize our data to facilitate this summarization. We choose analysis methods based on their ability to help us appropriately and effectively summarize the data. And we report summary measures based on their ability to communicate these results and communicate what we know about the truth for these populations most effectively, right? And so some of the ways that we organize our data, this is probably how you're used to seeing it. You have observations typically in rows going down a data set or a spreadsheet. Often they're individuals, sometimes they're aggregates, right? They're counties or their schools or hospital systems or whatever, right? Sometimes they're aggregated at higher than an individual level, but that's our unit of observation. And sometimes they're repeated measures within individuals, right? They're really smaller than the individual level. Many times these are healthcare encounters, right? You have many healthcare encounters within one individual. And that might be our unit of analysis, right? Our level of observation in our rows. And then usually across the top, right, in the columns, we have our variables. Right? These are the measurements, the characteristics or attributes about each of the observations. And we end up with a data set that looks something like this, right? Where we have observations going down the side and variables going across the top. Right? In a SAS data set, it looks something like this, right? Where maybe we have a unique ID. Each of these represents a different person. And this is just pretend birth certificate data that I made up. Month of birth, state of occurrence, state of residence, maternal age, recoded maternal age, number of prenatal care visits, birth weight, right? Those are attributes about each of these unique IDs, right? So we are used to seeing and organizing our data this way in a data set. So once we have our data in that data set, we apply some statistical methods to it. And this is where I want to ask the first poll question, which should pop up in just a moment. And it's, how long has it been since you had your last formal course in statistics? All right, so for half of folks, it's been more than 5 years ago. For some folks, 2 or fewer years ago. Okay, yeah, so that helps me to understand what to spend more time on, what to skip over in these slides. So thank you for taking a minute to respond to that poll. All right, so as I mentioned, what we're really trying to understand is what's happening at the population level, right? We want to summarize the attributes of the entire population, but usually, well, sometimes we do, sometimes we don't have the data for the entire population. So we have data from a sample or a subset of the population. All the data that we report are statistics, and we usually operate under the assumption that we never really know the true population parameters. Now, you may be saying to yourself, much of the public data that I work with, public health data that I work with, is actually population data. It's not from a sample, right? I have census data from all residents of the US. I have birth certificate data for all live births in my state. I have data for all males aged 65 to 84 in my city, right? These aren't sample data, this is population data. So am I really working with the population parameter, right? I don't need to treat this as sample data because it's not. Well, it's true that you haven't drawn a sample, but it's also true that it's useful to think of it as though it were a sample. And why does that matter, right? Why is it important to think of it that way? So certainly the entire population of people that can give birth in a given year in a city or a state or whatever your jurisdiction of interest is, don't give birth in that year, right? Everybody doesn't. Some of them do and some of them don't. And then the next year is another group, and some of them do and some of them don't, right? So, and then if you're looking at something like infant mortality, there are lots of factors that go into infant deaths that don't operate randomly, or at least they operate in I said they don't operate randomly. What I mean is they do operate randomly, or at least in very complex ways that we can't adequately model, such that the population that is born or dies in a given year is not the same every year, right? There's just some variation in the characteristics about that population every year. And so there's some natural fluctuation in any data that we're looking at, right? So it's useful to think about these as sample data so that we can assess that fluctuation in the characteristics, right? In practice, all data, I would say, should be reported and analyzed as though it were sample data, and summary measures should be considered statistics and not the population parameters. The distinction between population and sample is relevant really because of the theoretical underpinnings of the statistical methods that we often use. So most commonly, the statistical methods assume that we're using a simple random sample of observations that have been drawn from an infinite population, right? That's not ever the case, but that's kind of that's what these statistical methods assume. And often we're working with really large populations in MCH Epi, and that assumption is fine. And a simple random sample is one in which each member of the population has an equal and independent chance of being selected, which is also not always true, but that's what a lot of our methods assume, right? So it's important to understand these basic assumptions of our statistical methods because we apply them a lot and we use them a lot. So when we consider all data as sample data, we acknowledge that our analytic results will by chance be somewhat different from those of another sample that might be taken from the same population, right? The population of people in a state or in the country that could give birth in a given year changes some from year to year, but it doesn't change a whole lot from year to year, right? The folks that have live births in a given year changes a bit more, but also not a whole lot. But also it's really important to understand how much it does change and how much these things might fluctuate and how much we might expect them to fluctuate just based on this sampling framework. So if we accept that all data is really sample data and we're going to consider it sample data, then the landscape that we operate on is one in which the truth about a population can never really be fully known, and knowing the exact, for sure, right answer is not ever possible, right? So instead, we account for uncertainty and inaccuracy with sampling error or random error, and doing this is absolutely key and core to most of the statistical analyses that we do. Right, accepting that there's going to be some variation and assessing that variation empirically. So let's think about a situation where we have the National Survey of Children's Health, right, and we're working at the state level, but that National Survey of Children's Health does not give us the statistical power that we need to develop estimates at the level of jurisdictions that we need to develop estimates at, right? Maybe it's regions, maybe it's specific cities or counties. So we also have a state survey of children's health, right? So that we can better estimate these regional or more local statistics. So we have this state survey of children's health. We have this national survey of children's health. There is some overlap in the questions on the survey, some overlap in the indicators, right? Are those indicators always going to agree? Of course they're not, right? We could get, say, the percentage of children who receive specialty care. We could get a number from the National Survey of Children's Health that's a bit different than the number that we get from our state survey of children's health, right? Even if we have a similar sampling methodology, just different sample sizes, right? We can get slightly different estimates, right? We're using the same questions, we're just sampling different people. So which data are correct? Which one should we use if we're trying to make a decision about a program, right? And really, the answer is that probably neither one of them are exactly totally correct, the right answer. Probability theory gives us a set of mathematical rules that allow us to objectively or more objectively evaluate the accuracy of the sample statistics that we have and that we report. And there are certain probability distributions that describe how the values of a statistics would change if different samples, right, and theoretically an infinite number of different samples were drawn from a population. The sampling distributions provide a frame of reference for judging the accuracy of these estimates, and the sampling distributions that we most often use come from this exponential family, right? So that includes the normal distribution, the binomial, the Poisson, the chi-square, the F, and the exponential distribution. And these are really useful to us in public health, one, because a lot of the outcomes excuse me, that we are interested in follow one of these distributions often. It's also, these distributions are also really useful because in this exponential family, they can be completely defined by two parameters, the mean and the variance, right? Which have some pretty handy implications for us analytically. While there are different kinds of sampling distributions for different kinds of statistics, the normal distribution is kind of special in statistical analysis because with relatively large sample size, the distribution of statistics will be close to normal regardless of the original distribution. And this is based on the central limit theorem. So some sample statistics that we use very often, and we'll get back to that, that error piece in a minute, but let's first talk about some sample statistics that we use often. So we often use measures of occurrence, right? Like means, proportions, and rates. And we're trying to describe the average experience of an observation in a sample and estimate the average experience of that population. Right, so means summarize continuous variables and are assumed to follow a normal distribution. Proportions often, well, almost always, but often summarize discrete distribution or discrete variables and are assumed to follow a binomial distribution. Although some proportions more closely follow a Poisson distribution if the numerator is very small compared to the denominator. And then rates are based on discrete variables, often counts, that are typically said to be Poisson distributed. In addition to measures of occurrence, right, we're also interested in measures of association, and we use these a lot in our work. So sometimes we're interested in difference measures, right? The difference between two or more means or between two or more proportions. Sometimes that's called attributable risk or risk difference. Between a mean and a standard, right? Like the healthy people 2020 or 2030 standard, or the national average, or a proportion, the difference between a proportion and a standard. we use difference measures sometimes. We use ratio measures a lot, right? We use relative risk or risk ratios and prevalence ratios. We use odds ratios. We use rate ratios and hazard ratios. These often get used in epidemiology, right? Difference measures don't get used as often, and I would argue not as often as they should. And then we have those measures of association and measures of occurrence. And getting back to the error component, we need to assess the accuracy of those, right? Because we're assuming that these measures of association, these measures of occurrence that we're getting, that they are not the truth, right? They're helping us understand the truth, right? They're giving us evidence about what the truth is from a population level. So we use these probability distributions to evaluate how close or far from the truth our statistics are by calculating a range of values, which include, ideally, hopefully, include the true population value with a given probability. So this is what we call a confidence interval, right? And we calculate those around measures of occurrence, like means and proportions, and also measures of association, like odds ratios and attributable risks. And there's this standard formula for a confidence interval that we see in our statistics classes, and that we see in books and papers and stuff. We have the measure of occurrence or the measure of association plus or minus a critical value times the standard error of the measure of occurrence or the measure of association. Right, where this critical value comes from a probability distribution. The standard error comes from a formula, and it measures how much a sample statistic might change given all the other possible samples of the same size that could be taken from the population. And in general, we think that a narrow confidence interval indicates that a sample estimate is probably quite close to the population value, and a wide confidence interval indicates that the sample population, the sample estimate could be quite far from the population value. So really what a confidence interval means is that if we took a different sample from the population lots and lots of times, right, approaching infinity, and we took whatever measure we're interested in, the mean or the relative risk, every time, right, and we calculated for every sample that we're drawing, again, approaching infinity, 95% of the confidence intervals would contain the true population parameter. And that's a pretty clunky definition, right? I mean, that's a hard definition. That's a hard definition for me to think about and understand, right? And so it's a hard definition for us to explain to other people, right? So we get in this situation where we have a confidence interval and a measure of occurrence, right? Like the proportion of the population with health insurance coverage. And we observe a sample proportion of 85% of the population having health insurance, and calculate a 95% confidence interval that ranges from 81 to 89% of the population, right? So what's the interpretation? And what do we tell people? You say, well, if we could go to a whole bunch of different worlds with this same population, or a very similar population, right? Approaching infinite different worlds with a very similar population, and we looked at the percent that were covered by health insurance in all these different worlds, 95% of those confidence intervals would contain the true value, the true proportion, right? I mean, that's a difficult interpretation to get across to people. So we often take kind of a shortcut with the interpretation of a confidence interval, and we say something like, we're 95% certain that the true population, the true proportion of people with health insurance coverage is somewhere between 81% and 89%, right? And that's not exactly a correct interpretation of a confidence interval, but the correct interpretation of a confidence interval is really hard, even for somebody with a doctorate in biostatistics, right? It's just a clunky definition that's hard to think about. So when we're thinking about how to use confidence intervals for measures of association and why they're important for measures of association, again, these are differences or ratios. We have to take it another step farther and think about null values, right? And so the null value is really whatever our null hypothesis is. And often our null hypothesis is that the proportion of people with insurance in two populations is equal, right? So we have P1 and a P2, and let's say that they're equal. So let's just say that P1 is 0.2, P2 is 0.2, right? If we have a difference measure, right, 0.2 minus 0.2, right, the P1 population 1 proportion minus the population 2 proportion is 0, right? And that's our null value, 0. If we're looking at a relative measure of association, right, a ratio measure, it's 0.2 divided by 0.2, which is 1, right? That's the null value that we're interested in, right? So if these populations are the same, the risk difference, if the true population value for these populations is the same, the risk difference would be 0, and the risk ratio or the relative risk would be 1, right? So if the confidence interval for a difference measure, right, includes 0, right, that's the null value, then that's evidence that the means or proportions being compared might be equal, right? If 0 is not in the interval, it's evidence that the means or proportions are likely to be different, right? But if 0 is in the confidence interval, it doesn't mean that they're equivalent, that they are the same, right? That's really absence of evidence. It's not evidence of absence. So if 0 is in the confidence interval, it's kind of like a statistical shoulder shrug. Like, yeah, we can't really say that they're different. I don't know. I mean, I can't say they're different. For ratio measures, that null value is 1, right? If the confidence interval for a ratio measure includes 1, it's evidence that the proportions or the odds being compared might be equal. If 1's not in the interval, that's evidence that the proportions or odds are likely to be different. Right? And so let's say that we're looking at the proportion of females with health insurance compared to the proportion of males with health insurance. So we want to know, is there a difference between males and females? Is one more or less likely to be insured? And we have 87% of females with health insurance and 84% of males with health insurance, for a difference of 3%, right? 3% more females having health insurance. Our 95% confidence interval ranges from -1 to 7. All right, what does this tell us? I mean, what do we say? I'm asking, somebody tell me.
Feel free to unmute, or you can utilize the chat too.
Is this telling us that these are the same?
Yeah, this means the difference could be the same. They could be the same.
Yeah, they could be the same. Yeah, shoulder shrug. No difference. May not be difference because it contains 0. Yeah. So there might be a difference. We don't have really strong evidence of a difference. The population of males with insurance could be truly the same as the population of females with insurance. Now, the confidence intervals, the p-values that we're going to talk about, again, all of this is about building evidence, trying to understand the truth, right? These are all pieces and components that we use to try to understand the truth. It's not a an on-off switch that if it contains the null, then it's meaningless. If it doesn't contain the null, then it's meaningful, right? We need to look at this effect size. You know, even if this didn't include 0, is 3 percentage points, is that difference, does that matter? Maybe, maybe not. It depends on what we're trying to do. It depends on what our program or our intervention is trying to do. Maybe that doesn't matter, even if it was statistically significantly different, right? So we need to consider these effect sizes. We also need to consider the statistical significance. And again, we're building evidence toward understanding the truth. So what this is saying is, you know, it's a 3 percentage point difference. You know, that doesn't, for the purposes of this program effort, that doesn't strike me as very big. And then the confidence interval includes 0, which is the null value. So I think effectively for this situation, I'm going to say there's a good chance that there's not a real meaningful difference in insurance coverage by gender here. Right? So we have to sometimes stop and think about it. All right, so confidence intervals, they really only provide evidence for or against equality. And again, like I said, only strong evidence against equality. They really don't provide very much evidence at all, really, like a shoulder shrug for equality. But statistical tests and p-values go beyond this by telling us the probability that a difference that we see in our sample is due solely to chance imposed by the sampling process. Now, there could be other reasons for differences, right? There are biases, there are confounding, there's effect modification, there is all these other things. We use the epidemiologic framework to try to get at those, right? From a statistical perspective, right? We're looking at assuming that those things don't exist and saying, is this difference due to chance, right? And that's what a p-value tells us. And this is really all under the assumption of the null hypothesis. So the probability that we see a difference at this big or bigger due to chance alone is the p-value. And by convention, a p-value less than 0.05 is considered statistically significant. Again, it's not a meaningfulness on-off switch though, right? Sometimes people think of it as less than 0.05, it's a meaningful result. Greater than 0.05, it's a worthless result, right? That's not the way p-values work, and that's not the way that we should think about them. But that is the convention, is that 0.05 is the threshold for statistical significance. And again, we use probability distributions to formally test hypotheses about these sample statistics to calculate p-values. And there are formulas for these statistical tests and some appendix slides at the end. So, I don't think you want me to just go through those and spend a lot of time walking through those. There are things that you have seen before that you're familiar with, and you can take a look at those appendix slides. So I'm not going to spend a lot of time there. All right, so let's recap the statistical side of things, right? This sampling framework, and that's that statistics summarize sample data, and all statistics are estimates and therefore in error to one degree or another, right? They're not the truth. They're helping us to understand the truth. It's expressing the degree of error through confidence intervals or p-values is essential for interpreting the statistics that we report. Again, the confidence interval and the p-value is not the only important thing, right? That effect size is very important, and many argue very effectively and persuasively that the effect size is more important than the p-value or the confidence interval. But both of these things taken together, the effect size and the confidence interval, p-value, they're helping us build our thinking, build evidence towards understanding the truth. And then the basic components of any statistical analysis are one or more sample statistic, one or more population parameter that we're trying to estimate, a sample size, a sample variance and standard error, right? They're pretty much the same. They're related. If you have one, you can easily calculate the other. And then critical values from the appropriate probability distribution, right? This is what we most often use, this frequentist statistical approach. All right. I'm going to go into the epidemiologic framework and try to go through this quickly. Before I do that, any big questions about the statistical stuff that we just talked about? Okay, so we use those statistical tools. I'm happy to talk about those more through office hours or through email. But I think that this epidemiologic framework stuff is incredibly important to the work that we do. And the statistics stuff is important because we apply it through this epidemiologic framework. So we need epidemiologic frameworks, right? We need some guidelines to help focus our thinking, because we have to decide which indicators are important to consider. Right? We have so much data and so many indicators. We have characteristics about people, places, and time. We have risk factors and demographic factors. We have a bunch of outcomes. We have to decide what's important to look at this time for the statistics that we're interested in looking at. We have to think about what data are or will be available to measure the indicators. They might not exist, right? We might want to measure something and not have data for it. They might not be high quality. They might be poor quality. We might know that they're poor quality. We might know that the data exists, but we don't have access to it. We might decide that this is a very important question to try to answer, and we need to collect new data to answer it. Right? The epidemiologic framework helps us make these decisions. And then what analytic methods should we be using? Are we doing descriptive statistics, hypothesis testing, estimation? What are we doing? And then what is the analysis plan? How are we going to organize the data? What statistical approaches are we going to use? A systematic analysis plan is needed to effectively summarize all of the available data that we have or need to facilitate the core functions of assessment, assurance, and policy development that support each stage of that public health planning cycle. And without a systematic approach, it's likely that the data will not be successfully translated in the way that we want it to be to serve the people, the programs, the partners that we are trying to serve in our jobs, right? These are the things that we care about, is making improvements for the people, the programs, the policies, the partners that we are really trying to work for. So the most common mistake that epis and analysts that I've worked with make is that they just want to do stuff all the time. They just want to do stuff. But it's really important to stop doing stuff, to think about what you're going to do, and to make a plan for what you're going to do. Right? Stop, think, and plan. And that's doing work too. Right? So many folks that I've worked with say, well, this is the outcome that we're interested in. Let's just put everything in a model, everything we can think of. Let's just put it all in a model and just see. And why don't we just see? Let's just see what happens. Let's just put it all in a model and see what happens, right? And I tell everybody that I can, don't do it that way, right? You're trying to go to the end because you just want to do stuff, when you need to stop, think, and plan. Because when you build a model, you're trying to answer a specific question, right? You're not usually trying to just see. And so if you put things in a model, it's going to be hard to interpret because you haven't done all the steps to lead up to that. And then two, you might not have the right stuff in the model. You might have stuff that shouldn't be in there, right? And we can talk about, over controlling and colliders and all these things that that I think are really cool in epi methods. But you also might be leaving things that should be there out because you haven't stopped, thought, and planned enough to get all the important stuff in there. So you might have overlooked biases and confounders and interactions that are important. All right. So again, I'll say stop, think, and plan. It's not wasting time. It's using your time well, and it's using your brain well, right? You have so much expertise that if you don't take the time to stop and think, you have so much knowledge that if you don't take the time to stop and think, right, you're not being as effective as you could be. You're not giving yourself time to utilize all of your knowledge and your experience, right? Use your expertise. So stop, think, and plan. Let's think about some of the important components of a descriptive epi analysis plan, right? So this is not analytic epi, inferential epi. This is descriptive epi. First, we have to think about what variables do we want to look at. Again, we have all these data sets, all these different variables from outcomes and indicators and all these things. We have to think about what's important for what we're trying to do and the questions that we're trying to answer. And then we have to define categories for those variables if appropriate, right? Do we need to look at birth weight as a continuous variable, or should we look at it as a categorical variable? If we look at it as a categorical variable, should it be very low birth weight, moderately low birth weight, normal birth weight, and macrosomia, or should it just be low birth weight, not low birth weight, right? What is the best way to categorize this variable, if we should categorize it at all? Right? We have to stop and think about that. We have to develop a plan. Then we need to plan our univariate analyses. Maybe looking at the univariate distribution of birth weight will help us decide whether or not we should categorize it. We need to plan our bivariate analyses, right? What relationships do we expect to exist? And then what do we see existing in the data, right? We have to think through that and plan our bivariate analyses. We should construct shells of our potential tables. We should think about what we want to present because our goal is to communicate something, right? Our goal is to understand something and communicate it so that somebody else can understand it, right? So we need to think about how we're going to communicate this. And then what do we need in order to be able to communicate that in an effective way? So taking the time to sketch out, right, on a whiteboard or a sheet of paper or an Excel, what your ideal table should look like is not wasted time. That's time well spent. Similarly, drawing or sketching potential charts and graphs, defining the axes and the what lines you're going to have on it or what bars you're going to have on your potential graph. Again, the goal here is to understand and communicate to facilitate understanding. So it behooves us to spend some time thinking about how we're going to communicate. And then in that vein, articulate a potential narrative, right? If the data look like this, what does that mean? What sorts of statements, what might we make? If the lines are on top of each other, what does that mean? If they're crossing, what does that mean? If one is always higher than the other, what does that mean? Right? How do we think about this? And then what do we expect those results to be based on our experience and our subject matter expertise? Right? Many of the things analyses that we go into, we know what we expect the results should be because we know what the literature around this is, or we know what what other jurisdictions or states have found and things like that. Okay. So again, this is a lot to stop and think through, but it makes your analyses better. It makes your ability to communicate better. It's not wasted time, right? It makes you a better epidemiologist, I think. Because if we're better communicators, we're better epis. Something that you'll hear me say again, I think an epidemiologist who's half the analyst and twice the communicator is 3 or more times as effective as an epidemiologist who's twice the analyst and half the communicator. And so setting out this epidemiologic framework before beginning the analyses guides our study design or analytic methods, which guides the statistics that we report and the way that we communicate and how effectively we communicate. Right? So within and across data sources, we might have multiple versions of an indicator that we can select for an analysis. Right? So let's think about low birth weight. Right? We have the number of low birth weight births, right? That's the frequency of occurrence. We have the rate of low birth weight births per 1,000 live births, right? That's the rate of occurrence. We have some subpopulation frequencies. So we have the number of low birth weight births among people who enter prenatal care in the first trimester and among people who enter prenatal care after the first trimester. We have subpopulations for those rates of occurrence, right? The rate per 1,000 low birth weight births for people that enter prenatal care in the first trimester compared to people that enter later than the first trimester. We have geographic variations by county, by region, right? By urban rural designations. We have time trends in low birth weight births. Sometimes we're combining multiple of these things, right? We're looking at trends within a subpopulation of interest, and maybe that subpopulation is a geographic region, right? So we have all of these decisions that we have to make, and taking the time to think about things is so important because we have so many choices that we have to make. And if we are the people that are deciding and selecting what data other people see, right, that program folks or decision makers or upper level management, if we're deciding the data that they see, that's a lot of influence, right? That's a lot of responsibility. That's a really cool thing. That's why one of the reasons that I love epidemiology, but that's a lot of influence. Even if you are at the bottom of the organizational chart for your organization, if you're deciding the data that folks see by making these sorts of decisions, right? Which ones of these should we include? That's a position of great influence. And an epidemiologic perspective helps us weigh the advantages and disadvantages of different analytic strategies in order to choose between the one that best strikes the balance between specificity, right? We're looking at low birth weight. We're looking at very low birth weight among first births that enter prenatal care in the first trimester in the upstate region, right? Like that's very specific, but maybe that's too right? Maybe that's too specific. Maybe that's too much, because then if we have to do it for every region of the state, and we have to do it for first births, and then we have to do it for other live births, right? That we can quickly be very specific, but also very overwhelming, so that stuff is uninterpretable. So we have to try to strike a balance in order to communicate between specificity and interpretability, right? If we want to get at the truth, we want to understand the truth, we want to communicate the truth, but we want people to be able to understand what we're communicating. However, we want to make good choices, but our choices about which data to include in an analysis, right? They're not just theoretical choices. They're highly dependent on the availability of data and on the quality of data. And as MCH professionals, I know that we can all name indicators that we want to have, right? That would make us better at doing our job and helping us better understand the truth, but we just don't have them, right? For example, it would be great and very informative if we could report the incidence of child injury by type of injury and age. But we can't do it. We don't have it. We don't have data on every child injury that occurs in our area, right? So since we don't have that, we often use hospitalization for injury or injury mortality, right, to report instead, because that's the data that we have, right? That's a limitation, and we have to understand and acknowledge it, but we are limited by the data that we have. Another example in maternal and child health is we all know that the quality of the content of prenatal care visits is really important. We very, very rarely have data about the quality of the content of prenatal care visits. Right? What we have is data about the quantity of prenatal care, right? The timing of the first visit, the total number of visits. We can calculate indices and things based on that. But maybe that's not really what we want. That's just what we have, right? So our analyses shape around what we have. And sometimes we have to present more data than we would like because we're having to use several less than optimal measures in an attempt to approximate and triangulate the information that would be contained in a single indicator that is unavailable, right? So we're trying to assess something about prenatal care. So we have to look at all these measures of prenatal care because we don't know the content of the prenatal care visits, right? It's unavailable. We don't have it, and we're not gonna have it in all likelihood in most cases. Sometimes we use data that is of poor quality, and we know it's of poor quality because no high quality alternative is available, right? We know that the data around chronic diseases from the birth certificate, right? Pre-pregnancy diabetes, gestational diabetes, things like that. We know that data is generally of pretty poor quality. But sometimes it gets used because it's what we have, right? I'm not advocating for using that data, but that happens. And perhaps most problematic, sometimes we limit our thinking, we misspecify the questions we ask because of the constraints of the data. Right? We're not thinking about what we're really trying to measure, what we're really trying to impact or think through. Right? We are restricted to thinking about the data that we have. And that's a practical problem that we have in every type of epidemiology, right? And for us who work in applied maternal and child health epidemiology, in contrast to a typical epidemiologic study, which usually has a relatively narrow research question, the type of stuff that we usually do often focuses on multiple population groups and multiple domains simultaneously, right? Like if you work on a needs assessment, right? You're looking at a lot of different population groups. You know, maybe it's women, infants, children, adolescents, children with special healthcare needs. You're looking at health status and outcomes for these different groups, right? Low birth weight. You're looking at health services, right? Access to prenatal care. You're looking at health systems, regionalized systems of prenatal care. Regionalized systems of perinatal care. Across these domains, right? So this gets very voluminous very, very quickly, especially if you're trying to communicate on all of this stuff to a big group of people that aren't really data people, right? That see the title of this presentation and they say, oh my goodness, what have I got myself into? An hour and a half? Oh my goodness, right? So that's often our challenge in applied MCH epi, is a challenge of volume, more so than a challenge of complexity. And I think that's as difficult a communication challenge. And it, I think, makes it more important that we stop, think, and plan. And what's more, we're looking at these different population groups and these different domains. We're pulling stuff from all kinds of different data sets, right? With different strengths and limitations, right? Census data, vital records, Medicaid, hospital discharge, WIC, program data, all this different stuff, right? Nested within this already complicated task. Right? How important is it for us to stop and think and plan a little bit? So the challenge is to develop a systematic analysis plan in order to effectively summarize this wide array of data in ways that facilitates communication so that we can enable the carrying out of the core public health functions of assessment, assurance, and policy development that support each stage of that public health planning cycle. Right? And people say that descriptive analyses are easy. Oh man, I disagree. This is hard. Without a systematic approach, it's likely that the data that we have will be difficult to communicate, right? So we can't successfully translate it. We can't communicate the evidence and the truth that we're trying to get at. And if we can't communicate it well, then it's not going to be used well. Or worse yet, it could be misunderstood and bad decisions could be made. Right? So this descriptive epi stuff is really important. So again, I'll bring up these components of a descriptive epi analysis plan. You know, all of these, it seems like a lot to do. It seems like a lot of steps, but this is really important stuff. Stop, think, and plan before you get going. And then if we do a good job of doing a good plan and working that plan, the good descriptive epidemiology will often prompt more focused analytic questions about certain factors that might be causing an adverse health status or health service, right? So it will help us come up with better analytic epi questions that matter. Right? We should be striving to ask consequential questions. And one of our faculty, Pat Ocampo, who I believe is on this call, she is a leader in the field of epidemiology for decades, which means she started working on this at 5 or 6 years old, at thinking about things consequentially, right? Well-crafted questions guide the systematic planning of research. Formulating your questions precisely enables you to design a study with a good chance of answering them. And I think that you cannot come up with a good, consequential, precise question without first doing the good work of a good descriptive epi analysis. And that's, in my opinion, how you become a really effective epidemiologist. So, all right, one more poll question. Which of the following activities occupies most of your time during a typical day at work? All right, so a lot of you are doing descriptive epi, for a lot of your time, and there's a tendency for people to discount descriptive epi, right? But I hope that I've been making a good case for the importance of descriptive epi. So I hope that you feel that's time well spent, especially if you do it well. While this poll is up, I looked at the comments and I see Nika says that I find the vises of the basic descriptive data are often misunderstood, especially when done well, especially without explanation, like on data dashboards. And I agree. I think that that good data visualization, I think from a bigger picture, good data communication is really hard. And I'm excited to talk to you more about data communication in a couple of weeks, because we all have a lot that we can do to improve on data communication. As a component of that, data visualization, like a lot of people can do it, but not a lot of people can do it really well. I mean, data visualization is really hard and to do that effectively, right? So descriptive epi, that's hard work because that's hard to communicate. Analytic epi can be hard to communicate because of the complexity, but you can make that much easier if you do a good job of descriptive epi to bring people along. All right. So we are running short on time. I do not want to go over time. So the 2x2 table is, I put these slides in because this is also a good refresher, but hopefully this is stuff that you're familiar with and stuff that you've done. I've already said most of the stuff that I really want to say, right? And that was really hitting the descriptive epi stuff hard, and the importance and the complexity of descriptive epi. The 2x2 tables is a really important component to the way we think about and do good descriptive epi. It's something that you're probably familiar with, but I'm going to go over this just really quickly. And I'm going to skip this one entirely. So because you know why these are important. And if you want to read that later, you can. All right, so in a 2x2 table, we have the exposure. The way that I like to set them up is have the exposure over here on the left side, yes, no, and then the outcome, yes, no, across the top. And so if we're looking at a risk difference, right, the risk of having the outcome among people who are exposed, right, is A divided by N1, right? Among everybody that's exposed, N1, those that had the outcome is A. So the risk of having the outcome among those exposed is A divided by N1. The risk of having the outcome among people who were not exposed is C divided by N2, right? So that's a proportion, A divided by N1. C divided by N2 is also a proportion that we want to compare. We can compare them by subtracting them to look at the difference between two proportions, right? A divided by N1 minus C divided by N2. So that's called a risk difference or an attributable risk. If it's cross-sectional data, then it's really a prevalence difference. Or we can divide those, right? And that's a ratio measure. It's a relative risk or a risk ratio. Or if you're using cross-sectional data, it's really a prevalence ratio or a relative prevalence, right? So we can subtract them or divide them, right? Very easy. We also often use odds ratios. Some people are taught that you have to use an odds ratio for a case control study. They're often used in case control studies. You do not have to use them in case control studies. Odds ratios get used a lot because that's what logistic regression gives us. I won't, but I could go on for a long time about why odds ratios aren't really that useful, and we should be looking at these, right? These risk ratios or prevalence ratios instead. So just to put this in a more real world example, let's look at the exposure is 4 or more adverse childhood experiences compared to 0 to 3 adverse childhood experiences. And the outcome that we're interested in is poor mental health days, right? Self-reported poor mental health days. So 5 or more than 5 compared to 5 or less. So among people who reported 4 or more ACEs, 32.7% had more than 5 poor mental health days. Among people who reported 0 to 3 ACEs, 14.5% had more than 5 poor mental health days in the past month, right? So what we want to compare is this 32.7 to this 14.5, right? And we can either divide them, 32.7 divided by 14.5, gives us 2.25, right? So that's 2.25 times the prevalence of more than 5 poor mental health days among those with 4 or more adverse childhood experiences compared to those with 0 to 3 adverse childhood experiences, right? So we can divide them. Again, we can do the odds ratio, and depending on the prevalence of this outcome, it might be a pretty good approximation of this relative prevalence. Here, it's kind of close. But we could also subtract them, right? 32.7 minus 14.5, right? That's an 18.17 percentage point difference, right? So 18.7 percentage points more, it's 18.7 percentage points higher, the percent of, I'm tongue-tying myself, let me start over. The percentage of having the prevalence of more than 5 poor mental health days is 18.17 percentage points higher among those who had 4 or more ACEs compared to 0 to 3 ACEs. Right? None of this is hard, but the way that we think about it and the way that we communicate it is important, right? So it's important to think about what these numbers mean and how to communicate them. All right, big finish. 2 essential things for effective MCH-heavy practice, in my opinion, are analysis and communication, right? And I've already said that I think that communication is more important than analysis. Where you have to do good analysis, but knowing all of the most advanced analysis tricks, I don't think is as important for effective MCH-heavy practice as working on your communication. Scientific rigor is a requirement regardless of audience, right? We have to do a good job at the analysis, even if they're not complicated analysis, but even if they are complicated analyses, advanced methods, they don't always require a complicated communication, right? And there are, some methods that I like a lot better than others because I feel like I can communicate those results in a way that is more clear and compelling than others. And a well-planned epi-analysis will help you apply the right statistical methods and craft a meaningful narrative. It's super important, again, to stop, think, and plan. All right, and that's all that I'm gonna say right now, unless anybody has questions. Oh, except for this is a picture of Tumbleweed and Claire, and I'll let you try to guess which one is which. And I do have some appendix slides here. I'll post these slides to the team's page in the files for the pre-training webinars section. That's where these slides are going to be posted. All right. So I will stop sharing there. Thoughts or questions? Boo. I'm sorry. Was that exhausting? I'm tired. But was that useful? Was that way too fast on a lot of stuff? Or was it, a pretty good because you know most of this stuff, but it was good to, good to see it and think about it before we get into the next few weeks. All right, good refresher, useful. Good, good. Any questions? Where can we find more resources? About what? There are lots of resources. I'd be happy to talk to any of you at, I'm going to be, when we put out the roundtable schedule, I'm going to be participating in a couple of the roundtables. I have office hours that I'm holding open to talk through stuff with anybody who wants to schedule those and jump in those. So I'm happy to talk about additional resources for specific things. In terms of just some quick additional resources, I've also posted in the files under the general tab just an overview of some common statistical analyses used in public health. So some of the stuff that we talked about here is in here with some examples, and then this table that I put together with the outcome variable type, the predictor variable type, what type of univariate analysis you might do, bivariate, multivariable analysis you might do. So if this is useful, it's in the team site. Resources about code and coding. I have a lot of stuff related to SAS and Stata code that I'm happy to share if people are interested in that. Michael Kramer, who's one of the faculty here, he works in R. So if you're an R user, he's a great resource. So yeah, I think you could all reach out to me through Teams or via email or office hours. I'm happy to help in any way that I can. I'll put that SAS and Stata code resource that I put together up in the general tab files section as well. I will put it there, and I'll put these slides on Teams too. So Amanda is asking a bit more about why odds ratios aren't that useful. Let me touch base with Michael Kramer because he might be talking about that in one of the sessions. If he's not, I can record a short video and post it on our Teams page so that you can check it out if you want to and not check it out if you don't want to.
Okay, cool. Thank you.
Yeah.
I have a question, Dr. Smith. What is your recommendation or suggestion when communicating data or outcomes to non-data individuals? So working in public health, of course, there's a team of us epidemiologists working on the same team. We are constantly having data requests or asked to speak upon whether it be COVID data or MCH data to the community. Sometimes that is politicians, sometimes that is just local community members. And my question is, what recommendations do you have about breaking down some of the things that you just discussed in your presentation and to a layman's terms, or something that's easily digestible to someone who is going to be making decisions, or it is deeply impacting the community which we're discussing as well?
Yeah, what a great question, Anthony. Because I think, if it's not clear from my presentation, I think that's one of the hardest but most important things that we do, right? Is try to communicate this stuff that we know and we understand and we've spent a lot of time thinking about and working on, how to communicate that to somebody who spent no time looking at it and thinking about it, right? In a way that's understandable. And something that I think about a lot is thinking about it as storytelling, right? That's what I'm trying to do, is I'm trying to tell a story with the data. And if I try to tell somebody a story and I'm starting in chapter 4 of the story, it's going to be really hard for them to understand, right? I came up with the story, so I know what happened in chapters 1 through 3. But if I begin at chapter 4, right? So, and the analogy here is if I begin with like regression results, right? Or if I begin with risk ratios or odds ratios, it's going to be really hard, I think, for most audiences that aren't data savvy to understand. So I have to begin at the beginning and say, this is the outcome that we care about, right? Do we agree on that? And if we agree on that, then this is the characteristic or the predictor or the set of predictors that we care about. Do we agree on that, right? And kind of start there and tell the story and say, okay, well, the prevalence that we see for this outcome, and when I say prevalence, really what I mean is how often do we see this outcome out of the population of our state or our county? How many people do we have that had a low birth weight delivery last year? And what we want to know is, does that differ by insurance status, right? So let's think about it by insurance status. If we look at it by private insurance, Medicaid, no insurance, right? To try to keep it simple, do we see differences by insurance status? And I can show you, okay, I think that we do see differences by insurance status. And one thing that helps me understand how meaningful these differences are is this p-value that tells me that these really are different. But what I really want to focus on is how big these differences are. And then I want to think through, well, what else could be causing these differences, right? Is it really insurance status, or is it something else, right? Is it urban-rural location? Is it some other measure of socioeconomics, or is it some other risk factor? And so the way I'm going to try to understand that is I'm going to look at insurance status and low birth weight, like we just did, and I'm going to use a statistical technique to account for these other things, to see how much they might explain this relationship. And when I do that, I see this much still remains due to insurance status. So insurance status, the association between insurance status and low birth weight really isn't fully explained by urban-rural differences or these other differences that we've looked at, right? And so that's the approach that I try to take, is a storytelling approach where I'm trying to walk the audience through kind of every step of my thought process to try to understand, right? If I start with the relative risk of having a low birth weight birth, if you have Medicaid compared to private insurance, is 2.5, right? If I start there or anywhere close to there, I think I'm going to have a hard time trying to communicate that to a non-data savvy audience, even if I use textbook interpretations of a relative risk or more easily accessible interpretations of a relative risk. I think if I don't start with what are we interested in, why, and build from there, but that takes time, right? That takes engagement. That's a hard thing to do. And maybe if you're presenting in person, maybe you can do that. If you're presenting on a dashboard or if you're presenting in writing, that can be harder to do. So, that's why I think about data storytelling, right? And how do we do that through these different communications media that we have? I don't know if that's helpful at all to you, Anthony.
It's very helpful. Data storytelling is something that we've discussed as a group, and something that I've kind of looked into as myself. I think the biggest thing that you just said is engagement, that the biggest engagement. It is challenging at times to communicate over email or in short periods of time. If this person wants this number or wants this statistic specifically by the end of the week, then they kind of run with it the following week, and it is what it is. But engagement, there's definitely a narrative, there's definitely information that's additive to the data that I present or we present. So thank you for that answer.
And it's really hard, right? I think that it's important to acknowledge and admit that we're trying to do something difficult, right? Communicating in this way and to say it's okay that we're learning how to do this better, right? All of us are learning how to do this better. And as is being pointed out in the chat, you know, other people are trying to tell stories with data that they're maybe misinterpreting. It's hard not to get caught up in explaining the limitations of the data before explaining the actual result. Yeah, like that's really hard for us because the limitations are really important to us and we spend a lot of time thinking about that. Then how do we present data responsibly without presenting the limitations? Well, we really can't, but we don't want to lose the message, right? If we think that we can communicate some truth. So it's a hard thing, I think. Something else that we'll talk about in a couple of weeks because we're past time. We need to wrap it up. So we have a session that you know we'll be talking together in a couple of weeks about data communication, where we'll get into some of this stuff. And one of the other important things is knowing why you're trying to communicate, right? What is your purpose? And many data presentations that I see, the most discernible purpose I can come up with is that the presenter wants to show everybody how smart they are, right? And, you know, if we want to be effective, right, that's usually not going to be our purpose. All right. Yeah, so I really appreciate you sticking with me. I really appreciate your engagement and having some conversation here at the end, especially about data presentation and communication. We're going to talk about that a lot more. And in that session, I hope to hear from you about what's worked well for you in your experience. So again, I thank you so much for your time. And I'm so excited about what we have to come as we get into the MCH Epi training course in earnest next week. I hope that you're excited too. I can't wait to see and hear from all of you again next week. Ashley, anything else to close us out?
No, thanks everyone for giving us an extra 9 minutes of your day. So you'll be hearing more from me over the course of the next couple of days, and just to kick off, email expected Monday morning just to get you ready to rock and roll for the next 3 weeks. So thank you again, everyone.